we'll discuss when do these fractures need stabilization, which are the patients who will progress to neurological deficits, and what are the options available with you. So we came with a paper where we published the spine at risk signs in patients with osteoporotic fractures, and we came up with the 7 signs. One is burst fracture, middle column involvement, vacuum sign, local kyphosis more than 20 degrees, retropulsion, spinal canal encroachment of more than 25 degrees, tricolumn injury, and multiple wedge compression fractures. So if a patient in your X-ray has more than 3 of these signs present, then he is at a risk of progression to neurological deficits. We had a conclusion where we saw about 55 patients, and 3 or more signs present in these patients is a warning sign for progression to neurological deficit. Now, ideally in these patients, an anterior reconstruction, a vertebral column resection, and posterior stabilization is necessary. But most of these patients are elderly, and they do not tolerate these comorbid procedures. So we categorize these patients into 2 types. One is patients who have comorbidities by the Charlson's Comorbidity Index. That is an index which analyzes the patient's age and other comorbid conditions. Does the patient have cardiac disease, renal disease, any history of metastasis or cancer, or any, for that matter, any medical problem that puts the patient at the risk of anesthesia or the risk of death. So those patients were different. Patients who have the Charlson's index with more than 3 comorbid conditions, like if patient is diabetic, renal disease, and this patient has a long time survival rate is less, in those patients the protocol is different, and the patients who are relatively fit, 70 plus or 65 plus patients with osteoporotic fractures and neurologic deficits, the treatment pattern is different. Now here is this 73-year-old female patient, D12 osteoporotic fractures with dynamic instability, paraparesis, focal kyphosis of more than 30 degrees, and greater than 50% collapse. Now this patient underwent a vertebral column resection, cage placement, and a fixation 2 levels above and below. Always works. It goes good recovery. It's a solid fusion. You also supplement the patients with medical management with teriparatide, calcium and vitamin D supplements, also as well as denosumab. So medical management is equally important along with this treatment, and this doesn't fail. So you know that this screws will not get loose and the patient will do well. Now another patient, 70-year-old female, L3 osteoporotic fractures, dynamic instability, greater than 50% collapse. This is L3, usually the retropulsion, kyphosis, neurodeficit, vertebral column resection, and single level MIS stabilization can be done and does give good results in these patients. The patient doesn't have a lot of comorbidities, so she does tolerate this surgery well. Now another patient, D12 osteoporotic fracture, greater than 50% collapse, focal kyphosis, more than 30 degrees, neurological deficit. Again, vertebral column resection, 2 levels above and below, does work well in all these patients, and you are relieved that this patient is going to do well. Now this is another patient, 78-year-old patient, wheelchair bound, Asia C, now other spine at risk signs positive, vacuum sign, kyphosis, loss of anterior vertebral body height, retropulsion. Now this patient had a lot of comorbidities, so underwent a cement augmented stabilization. Augmenting the cement with fenestrated screws, you can avoid a long segment fixation in these patients because you have to do as less as possible and fuse less segments and achieve the result. So the vertebroplasty cement, it gives the anterior stabilization like what we get in a vertebral column resection, and the MIS stabilization will correct the local kyphosis. Even if you don't decompress, these patients will do well. For these patients who are elderly with a lot of comorbidities, this technique works well. Another 82-year-old male, Asia D neurology, vacuum sign, kyphosis, loss of vertebral body, retropulsion, encroachment, instability score 4. Again, MIS stabilization, vertebroplasty. It does work well in these patients. And then another D9 fracture in 65-year-old male, non-walker after fall in bathroom. It's an incomplete burst fracture. You can get away with a vertebroplasty and MIS stabilization in this patient. So we have 2 options in these patients. You can get away with MIS stabilization and stabilizing the anterior column with vertebroplasty. If the deficit is dense, patient is fit, you should vertebral column resection and 2 levels above and 2 levels below stabilization also gives excellent results. So, as we saw, the vertebroplasty stabilizes the anterior column, and the fixation provides stabilization of the middle and the posterior column. So, prolonged monitoring is necessary, and we identify the spine at risk signs in these patients, and patients who are fit with less comorbidities, we can go ahead with the vertebral column resection and stabilization. Patients with more comorbidities, my choice of treatment is vertebroplasty and MI stabilization. Thank you.